Hi, I'm Dr. David Cotter, a board certified dermatologist practicing in Las Vegas, Nevada at Las Vegas Dermatology, where I'm the director of clinical trials. And I see a lot of medical dermatology across the pond from my friend here, Jim Del Rosso.
Yeah, we're not too far away, right? So we're very close to each other, but we don't get to see each other a lot in person because we're so busy doing what we do. Jim Del Rosso, a dermatologist in Las Vegas, Nevada, at JDR Dermatology Research Center, which is affiliated with Thomas Dermatology here in Las Vegas. I've been practicing here since 1997, so I have a few years on you, David, but 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 certainly not much smarts beyond what you have. So it's going to be great having a discussion today.
I'm always happy to chat with you, Jim.
So, David, just thinking about, you know, the last 5 years or so, right? And so when you were in your residency, which is not that long ago in San Diego, it wasn't long before you learned how to clinically recognize prurigo nodularis. I mean, it has a pretty characteristic clinical presentation. We learned about it as a manifestation often in atopic patients, but sometimes other associations. But we really didn't know a lot about it. But it's one of those things when you saw it, you knew what it was. And now all of a sudden the volume's cranked up and it's hard to go to any journal or to any meeting where there's not presentations and articles, webinars, and information in depth about prurigo nodularis. And we now have FDA approved therapies for prurigo nodularis specifically. So, how did you see that in the time that you've been available developing over the past few years?
Jim, you're 100% right. I couldn't agree with you more. Prurigo nodularis is one of these diagnoses that we know when we walk in the room. It's a doorway diagnosis. You see it and you know what it is. And certainly there may be different things in the skin that could be driving that. But I'll tell you what I tell my patients. We diagnosed someone with prurigo nodularis yesterday. And I say, listen, it sounds like a funny word, but you just break it down. Prurigo means itchy, nodularis means nodules. You have itchy nodules in your skin, and that's what we see clinically. That's what you're experiencing symptomatically. And historically, it's been one of these diseases that's been tough to treat. We used to have to give patients antipsychotic and anti-neurotic medicines to stop picking at their skin and make them so tired that they couldn't go at it, to turn down the volume in their nerves. We'd use medicines like amitriptyline and gabapentin because we knew there was a neuropathic component. Something about the skin was communicating with the brain to tell them that there's an itch and to drive this itch, scratch, itch cycle.
Right.
And what's happened, to your point, Jim, is it's been a revolution in this space because as we have developed a better molecular understanding of the disease, it's enabled the development of targeted pharmaceuticals that are actually able to treat the root of the condition.
Well, it took being able to look at what's happening with a variety of different basic science techniques that we didn't have before. So having seen this in my residency from 83 to 86 and deal with it over a long period of time, you're talking about utilizing antipsychotic and anxiolytic medications and things. As the clinician, you often felt like you needed those after a while because it was very difficult to figure out how to help the patient. We knew that atopic patients would have that as a manifestation of the disease, but we saw it in other individuals, usually older, not very much in childhood, early childhood or adolescence, possible, but not very often at all. And we often thought that it was a manifestation of maybe some psychiatric situation the patients had. But thinking about it, that condition itself has led to a lot of the people being depressed and anxious. So it's sort of which came first, the chicken or the
Well,
egg. But
well,
now
exactly.
we have a better understanding. And I think what really helped was when they noticed that type 2 inflammation is a part of the disease. It doesn't explain the whole disease, and we can get into that. It's part of the disease, and we can direct treatment with that. When dupilumab was being evaluated for this entity, it was noticed. And I remember reading it, and I'm saying, in all those years, we never asked the patient, do you itch anywhere else? And many of the patients said, yeah, I itch in other areas of my skin, but they were so focused on those areas that, like you said, are sensitized to go after just those focal areas in the skin that we could bounce around. right? And so that leads you to believe it's not only focally within the skin, there's something else going on with cytokines or mediators more on a systemic basis. And to me, that was a critical observation, which is why the therapies we have now, the two biologics that are approved, are given as systemic therapies and are making a much bigger difference compared to anything we had before.
Exactly. And part of that elevated understanding of the mechanism of this disease certainly involves cytokine biology. And I remember being a resident and hearing from Larry Eichenfield, it's going to be a board's question. The itch cytokine is IL-31, and IL-31 is parked within Th2 immunity and Th2 inflammation. And so we know that IL-4 can drive proliferation of these T helper cells, these Th2 cells, and we see IL-4 and IL-13, TSLP, some common cytokines we're familiar with in atopic dermatitis. And one key mediator that is also a Th2 cytokine is IL-31. And the interesting thing about IL-31 is it doesn't just tell your body that you're itchy. When I talk to patients about it, I like to use the term it's the mosquito molecule. Because when you've got something that's itchy in your skin, your brain senses that via IL-31. You actually have IL-31 receptors on sensory neurons. You have them in the dorsal root ganglia in your spinal cord. And as you can imagine, if you are sensing itch and communicating that to your brain, it can create a reflex arc that drives scratching. But even beyond that, Jim, IL-31 receptors are on immune cells. They're on keratinocytes, they're on fibroblasts. So it can also have direct effects on barrier dysfunction and on fibrosis, which gives you this bigger picture of PN as a disease state, wherein you don't just have the sensation of itch, but you also have maladaptive remodeling of the skin where you're having worsening barrier dysfunction and you're also having fibrosis, which can account for these thickened nodular lesions that our patients experience.
I agree with all that, but I also look at it a little differently in that there are several dysregulations. TH2 is one of them, and IL-31 is a part of that. And yes, it is the board question that it's the itch cytokine, but it pigeonholed people thinking that that's all it does. And like you said, it does many different things, but there are several dysregulations that are involved. There's dysregulations within the fibroblast system, which is what leads to the nodularity and the hyperproliferation. There's neural sensitization and dysregulation. There's Th1, there's Th17, there's Th22. There are so many different dysregulations. And IL-31, like you said, there's receptors and it's also produced by several different cell types. So it can be coming at you from air, by sea, by underground, by land. It can attack you on several different levels, which is why we have to think of it broader than just a single cytokine. These systems don't work in a vacuum. They're all happening collectively at the same time.
Exactly. And still, though, this molecular understanding of disease can be hypothesis forming and help direct clinical development of medications. And one medication we've alluded to is nemolizumab, a monoclonal antibody that blocks the IL-31 receptor. And theoretically, this would make sense. If you're blocking IL-31 signaling, we know that it's important for itch and fibrosis and hyperproliferation of keratinocytes, et cetera, as well as neural sensitization. That might be a reasonable approach. If we can block this molecule, can we mitigate some of the disease symptoms that our patients are having? Can we ameliorate their disease state? And that's exactly what was done in the Olympia 1 and 2 trials. These are randomized, placebo-controlled, double-blind trials, and of course, with a long-term extension to come afterwards. And the Olympia trials, Jim, were actually the largest ever PN studies that we have
Right,
published to date. There were over 500 patients studied with a primary endpoint to look at itch as the main readout and then skin healing as a secondary endpoint. So they wanted to see the proportion of patients that have that 4-point reduction in their itch. And the second primary endpoint, not a secondary endpoint, but the second primary endpoint was a
right.
dual co-primary endpoints were the reduction in the IGA score. So we wanted patients that came in moderate to severe. That's a lot of PN lesions. A severe patient has over 100 lesions
Right.
to get down to less than five. Zero is zero, and almost zero is five. So a
Up
zero
to
and a one
five. Right.
up to five. Very,
Right.
very robust. And that's different than the way some of the other drugs have been studied. When we look at the Prime 1 and Prime 2 that were done for dupilumab, they used the 4-point itch reduction as the primary endpoint, and IGA success was a secondary endpoint.
So, and the other thing is, when you're To me, it was not surprising at all, having known a lot about nemolizumab and working on it in development and in discussions, advisory discussions, that it was not surprising at all that it was going to have a rapid effect on the itch. Dupilumab did, but it took longer. The trials were expanded over a longer period of time, and it was more robust. They're not direct comparisons. It was more robust and it was quicker with nemolizumab. And that didn't surprise anybody. But the other differences to consider, because dupilumab did improve patients too. I mean, it got the FDA approval, but it takes longer to climb up to have that effect in most patients. But also there are other differences in the molecules in terms of what you're thinking about. Interleukin 31 is not involved, for example, in modulating the eye. So, at least in the clinical trials, you didn't see conjunctivitis or blepharitis or ocular surface disease any more than you might in the placebo group, remembering that some of those people are atopic, so they could have that issue anyway, right? And so there are other reasons to look at selecting one molecule versus the other beyond just even the cytokine inhibition.
Well, absolutely. Efficacy is always one side of the equation, safety is the other, and then of course access is the 800-pound gorilla in the room. We take a holistic approach to all of our patients, and understanding trial data is helpful in guiding that. We know that both of these medicines are generally safe, but when you look at the safety for Nemluvio, I mean, this drug is so clean. When you look in the placebo-controlled portion of the trial, the 16-week part of the trial, the AEs that you see placebo adjusted are almost negligible. There's a slight signal for headache that's about 3% compared to placebo adjusted. And when you lump in all of the eczema related conditions, which you happen to see eczematous flares in any trial that's including patients with atopic dermatitis. And in the NEMO trials for PN, about 30% of patients had comorbid AD. None were flaring when they came into the trial, but these are
Well,
patients that have atopic
they
dermatitis.
couldn't be flared and they couldn't be more than mildly atopic. They didn't allow moderate to severe disease in the trial. So there was a significant number of people that did not have atopic disease at all, and that's important. So they don't
Mhm.
have to be atopic for it to work. So anybody that has
Exactly.
prurigo, but the other
They,
thing that I think is really important about it is the volume of the injection is only about a half ml
yeah,
and
point 0.9 mils, I think.
0.49 0.49.
.49.
It's about a half of a ml. So a lot of what you feel, the diameter of the needle and how thin the needle is, the sensation of that needle going in the skin, but also if you're injecting a larger volume, that's more uncomfortable, right? So
Absolutely.
so the actual injection itself, patients were not, I'm not saying that they didn't feel anything or have any discomfort at all, but it was extremely low. And so
There's
injection site reactions, which could be what they're sensing or maybe a reaction to the protein in some occasions, it was very, very low with nemolizumab, which I think is an advantageous consideration. Plus, it's every 4 weeks automatically, you know, um,
absolutely.
different than for atopic dermatitis where it may be dosed a little bit different. It's dosed every 4 weeks, and you may adjust it based on the weight if they're
Absolutely.
right.
The dosing for Nemluvio is very nice. And like you said, Jim, it has the smallest injection volume of any of our biologics to treat AD or PN. It's objectively, in my hands, the least painful of any of these medicines. We've had
Right.
patients switch and they're laughing. They're like, that's it? I was expecting more. They're so surprised. And it has to do with that low injection volume and really no injection site reactions, just like you said. In terms of the dosing, it's easy. Q4 weeks from the get-go, which is different than other medicines. For AD, like you mentioned, Jim, you have the option to flex to Q8 weeks, which is very nice for some of these patients. You can do that as early as week 16 and you maintain your easy scores. I know we're talking about PN tonight, but it's nice to think about these conditions more holistically and where they might come into play.
So the situation that I think about that is not addressed necessarily. Let's say you have a patient that is atopic that has PN and you're treating them every 4 weeks and you're out about 4 months. They're doing great with the atopic dermatitis. The PN was part of the atopic disease, right? Which we often saw before. We knew that it would improve as the atopic dermatitis improved. But now you're deciding, do you go every 8 weeks with the atopic dermatitis, which is not technically the dosing for prurigo nodularis? In my mind, I'd say yes. give it a shot because you already got the PN. You're not starting out with 80 nodules, right? You got the PN under control. You, it's very easy to surmise that if you're controlling the atopic dermatitis, you're also going to control the PN. But if the PN starts to merge back, you just go back to your every 4 weeks. That's how I would do that. I just wanted to
That,
see what you thought.
that's a very reasonable approach, and I like happy patients and I like shared decision making. So what I would do in that scenario is I'd say, listen, hey Jim, we can definitely flex your dose. Let's see how you do. If you start having some breakthrough itch, perhaps we can
Yep.
resume Q4 week dosing. And that's the one thing you do see in the atopic dermatitis trials for Nemluvio as you follow these patients out to 1 and 2 years. The easy scores are maintained very consistently, even with Q8 week dosing. But there
Right.
may be a slight drop off in some of the itch severity scores. And
Right.
and one consideration is in the trials for atopic dermatitis, these patients were allowed to use topical corticosteroids as needed. Think of it as a little
Right.
touch-up paint if they
Yes.
did have a flare, which is different than the Olympia trials for PN. Those were true monotherapy trials.
Right.
And so I'm always happy to flex my patients. And if they have some breakthrough itch, we just get them back on that Q4 week dosing.
Exactly. We in the real world, where the package inserts are defined based on what's submitted to the FDA for FDA approval. They're not monographs that tell us how to treat patients in clinical practice. They're not meant to be, and the FDA will tell you that they're not. They're based
And,
on the data that you're looking at for approval.
and the
So
re-
we need to adjust based on what we see with our patients, which you just said very well. That's
yeah,
exactly what I would do.
And the reason why I don't mind flexing the dosing is because if someone does have some breakthrough itch, Nemluvio works so fast for itch. We're talking in the clinical trials as early as 48 hours after the first dose. 15% of people are already having a 4 point itch
Right.
reduction. And not
Right.
only does it work fast, it continues to work extremely well. When you look in the OLE, you see that 95% of patients are having that 4 point itch reduction
Right.
in the open label extension. So it captures just about everybody and it captures people very, very quickly.
Yeah, the itch reduction, now, what I would tell people is you're going to see the itch reduction quickly, but yes, 48 hours, but it takes time. Those are
Yeah.
so I don't want the patient to be thinking, go, if it's the first week and I'm seeing some reduction, but I expected more, and pull the plug. They need to recognize that that's the early part of the trial, but as you go further and further, you capture more people getting higher levels of success. So I don't want them to cut it short too soon because we're over promising about the itch. I rather under promise and have them say, man, within 3 days my itch was gone, right? Because
Yeah.
or significantly gone. So I'm careful about how I explain it to the patient because I want them to come back and be happy, not be thinking, oh, I should have gotten much better already. Right.
My pearl for patient counseling would be if you do well early on, generally you will continue to do well and you will do more better with more medicine. And
Right.
so it's very promising when you see an early itch improvement. If you're doing great after a couple of days, 1 to 2 weeks in, when I see you back for 4 weeks, just know that there's even more benefit to come. The
Right.
fact that you're responding so early doesn't mean you've maxed out your response. It just means
Right.
that you're on the correct trajectory. And we get you to 16 weeks. You're going to be doing even better at 16 weeks than you are week 4.
But if they didn't see it, keep going.
Keep going.
If they didn't see that, wow, it's gone. Keep going because you'll get there. Right.
Exactly. And if
That's
you're not there at week 16, doesn't mean you won't be there at week 52. In the
exactly
pivotal
right.
trials, about 50% of patients achieved that 4 point reduction at week 16, which was 3 to 4 times higher than placebo. But again, as I mentioned earlier, you get those patients out to a year, it approaches 90, 95%. And
Exactly
so
right.
so more time, more better. And because this medicine is so safe, I don't have a lot of concerns with keeping patients on it. People do very, very well, very few side
I
effects.
have no concern about actually with the biologics in general that we're using, and Nemluvio certainly, nemolizumab. I'm not really. I'll keep an eye out for safety, but safety is not, what I'm thinking about. And in these patients, I really expect to see dramatic improvement in the majority of these patients early on, right?
Mhm.
But my point is, go longer. Don't give up too soon if that individual patient was thinking they would expect more.
Exactly. The cool thing about having Nemluvio for patients with PN is it's redefined the space. As we alluded to earlier, these were hard cases to treat. We didn't have great targeted therapies. We had medicines that were sedating. They came with a lot of potential psychosocial stigmata. Oh, why are you prescribing me an anxiety medicine, a antipsychotic? I don't want to take that. That's not what I have. And our patients were right to say that. We needed to do better. And in this era, we can actually offer them something that's safe and targeted and designed specifically for their disease. And it's re-energized me to treat PN patients. It's been so wonderful to have great medicines, and it's been life-changing for so many of our folks. They come in, they have these nodules all over, we put them on Nemluvio, and they get better. These nodules fade. They're able to show their skin, wear their shorts, wear their
Exactly.
swimsuit, go to the pool, and live their best life.
So I'm kind of laughing to myself because David, you're spoiled, right?
Oh
You
yeah.
you didn't have from 1986 up until you got out of your residency where we didn't have all these targeted medications and get re-energized. We had injectable corticosteroids, we had high potency corticosteroids, we had anti-anxiety, antidepressant medications, and then oh gee, try cyclosporin. Great. Yeah, it helps some people partially, but you had to think about all that baggage that came with it. Now we're dramatically affecting people with a therapy that is not likely to harm them if they had an underlying malignancy, if they have, I'm not worried about if they do have an underlying kidney disease or some of the other things that are going on. And I would be concerned about that if I was starting cyclosporin and methotrexate in the old days.
100,
So
100%.
we have such a runway of easier management of the disease from our side of it and much better for the patient, which you described, many different ways so well. It's a great it's never good to have PN, but if you had to have it, this is a good time to have it. Right?
I couldn't have said it better myself, Jim.